On a few, we'll end our presentation on a few brief highlights of some of the other system transformation efforts that we're doing within our department that are worth noting. However, before we can get started on the story of system transformation, let me first tell you what CYF is and where we sit within the larger organization. Next slide. So we want to start by locating where we sit within the Department of Public Health. The San Francisco Department of Public Health is the service delivery wing of DPH, and the San Francisco Health Network includes 2 hospitals, Zuckerberg San Francisco General and Laguna Honda, and has an ambulatory care division that includes primary care, jail health, whole person care, maternal, child, and adolescent health. A few years ago, BHS used to be under ambulatory care, but a few years ago, BHS moved out from under ambulatory care directly under Dr. Grant Colfax, our DPH director, and there's still a dotted line to the health network. This move was prompted for a couple reasons. First, BHS is the largest service delivery unit within the department and a complex county mental health plan and drug Medi-Cal organized delivery system. And secondly, in December 2019, the Board of Supervisors passed an ordinance amending the administrative code to establish mental health SF. They combined the BHS and mental health SF director positions and moved it under Dr. Grant Colfax. And circled in red is Dr. Hilley Cunnins, our BHS mental health SF director. Next slide. So zooming into BHS from the larger DPH org chart, this org chart represents the BHS cabinet. These are the leaders directly under Dr. Cunnins. San Francisco County restructured its behavioral health division similar to other county behavioral health departments with the creation of 2 new positions. The system of care director, which will be circled in red, which is where we sit, as well as other systems of care sit, which I'll speak to in a moment. And then the other function that's worth mentioning, I'm not going to get into all of these boxes, but it's important to note our managed care director, Imo Momo. BHS has a managed care function in terms of our mental health plan and drug Medi-Cal organized delivery system. So this is where the regulatory quality management functions sit within BHS, utilization management. It's also where our Office of Coordinated Care sits that oversees a number of functions, including our County Behavioral Health Access Center and line, which is significantly impacted by the CalAIM transformations as we work to coordinate across different functions and plans across the county. The system of care is where the bulk of the service delivery system sits. And so I'm going to move on to that in the next slide. So zooming into the systems of care section that Max Rocha oversees, you can see that the Children, Youth, Family system of care is one of many systems of care. We oversee the services that are delivered to children, youth, and families. The other systems of care include the transitional age youth, the older adult, the substance use disorder system of care, which is currently focused on adults, the residential system of care, which is focused on adults, and our comprehensive crisis and Hope SF is their own system of care as well. So zooming in closer to just the Children, Youth, Family system of care, we've got programming for babies and youth, birth to 18 and up to 21. We have integrated programming across the continuum of care with the school district, child welfare, and juvenile justice systems. Many of our youth access services through these partnerships. In addition, primary care is a big point of entry, and folks also come through by self or community referral. In terms of the system of care we oversee, we have programs that span from prevention all the way through mental health services that are embedded within residential and other home-based or in-custody placements like juvenile hall. Our budget within CYF is over $100 million. We've got about 9 CYF dedicated, 12 when we think about other comprehensive clinics. Civil service clinics that are directly under us with an FTE of about 170 when fully staffed, and we contract out to about 36 community-based organizations that deliver approximately 100 different programs in total. Our next slide is just here for future reference. I'm not going to speak to this, but when you all get the slide decks, you can see the types of programming we have within each of the different levels of care, just for future reference. And now that you kind of understand where we sit and what we do, I'm going to pass it on to Dr. Lisa Hilley.
Good afternoon, everyone. I am sort of going to give an overview of CalAIM at the macro level and then pass it on to Ritchie to really talk about what we're doing on the ground with CYF. So you all have probably been living and breathing this too. This change is impacting everywhere, everyone. But CalAIM outlines the expectations and mandates for Medi-Cal funded delivery all over California, including mental health, our county mental health plan, which is what we're here to talk about today. Our goal really overarching is to give just one piece of this puzzle and highlight some of the system changes that we've been grappling with in CYF. Thanks, Ritchie. So as you all probably know too, that Medi-Cal beneficiaries can access services through multiple doors, lots of big systems. There's the Medi-Cal managed care plan. This is here in San Francisco, which houses primary care, many of you, inpatient services, and really the behavioral health treatment for mild to moderate mental health issues. There is fee-for-service Medi-Cal here, which certainly not an expert about, but one of our entry points for Medi-Cal beneficiaries. Then we have our county behavioral health, which is the mental health plan, which we represent a piece of that. Houses the treatment for substance abuse and use disorders, and then the treatment for more severe mental health issues. And of course, our partner in human service agencies, which really handles all enrollment and eligibility. So we work really closely with them. Today, we're going to talk about that third bucket because that's our mental health plan where we're operating from. But one of the things we want to highlight today is that, CalAIM really pushes us to get to know each other, to coordinate together, to be different as we move forward, both in that step up and step down. So I know there's been a lot of collaboration and work over the past year and a half to figure out how we do that together. So that big picture CalAIM overview, it was exciting. I walked in my first day here in San Francisco County, and Farah said, guess what? We need you to help lead this for our children's system. And so it has been a total fast train ride and really exciting. But California Advancing and Innovating Medi-Cal really does align with the visions and the values of CYF to make this our programming, but the whole state more equitable, coordinated, and person-centered. With that end goal, all of our goal, I think, shared is to reduce those health disparities we all see all around us all the time. What CalAIM does that's exciting are these big picture initiatives, big impact goals to increase that coordination, actually demand coordination in a new way with things like benefits of enhanced care management, which is set within primary care. There's things like community support, so lots of new benefits. Streamlining policies, standardizing across the entire state, which is a massive underhaul, promoting and pushing, but also allowing for claims and reimbursements on social determinants of health that has been decades-long struggle and fight to get there. So really excited to be part of this for even a small piece of the work. We're not talking through this one either. It's a big picture. Again, you all are probably integrated in here in many places, but this is a snapshot of a 5-year timeline for just the first parts of CalAIM, and so wanted to show how massive it is. We're like one row in here, but also looking around us and seeing the impact across the state on all kinds of areas, from dental, juvenile justice benefits and packages, foster care, of course, and there's a lot going on. This is years in the making, and we're again, feeling the first part of that now. So drilling into like the CalAIM impact for us in behavioral health, especially in the mental health plan. So our piece of that puzzle, we wanted to talk a bit about how CYF started to tackle that. There's that massive, it's an overwhelming amount of information to digest. And we started to build work plans around different buckets of this work. So we could, one, stay together and organized in our thinking, but also start to get the word out to the providers we support. So the administrative and structural changes sort of came at us first, and we looked at really shifting our practices, our policies. We're still doing it. We're not all the way there. But, the state of California really came out with data that about 40% of behavioral health clinicians and providers' time was spent on documentation alone, just documentation. So 40% of people's week, we know that was also impacting burnout. We already have a staffing crisis. And so really alarming information, and have worked hard. We'll continue to work hard to really reassure people that spending less time on documentation is okay. If not, it is now best practice. That's a hard one to shift for people. And then payment reform. We're in the middle of that now. We have big changes coming in July in terms of how providers get paid, which is really important, but also how we've set up our structures for claims, invoicing, coding, and all of that. Seems small in some ways reading through the CalAIM initiatives, but it's a massive overhaul. So we focused a lot of our first year on that. We're moving more and more excited to be in the practice changes, which we're going to spend a minute just highlighting because it feels so significant, maybe to me personally in my career, but the change of medical necessity and access criteria is huge for children and youth. And then that CalAIM really, again, promotes, encourages, but mandates that care coordination happens, that we zone into social determinants of health that were never reimbursable before in behavioral health. I hope by the time we leave, like one of the things that's really struck the three of us in our work together is shifting from that individual pathology model to a much more trauma responsive approach to care. And if you really embrace the spirit of CalAIM, we hope it'll get us there. So shifting those sort of administrative structural changes really from compliance focus to quality. And that's no small feat when people have been really overemphasizing the rigidity and the sort of auditing that's important, but wanted to shift that and flip it a little bit to more about the quality. So there was, looking back, emphasis on signatures and treatment plan start and end dates. I used to hear a lot that this young kid doesn't meet medical necessity, we can't serve them, or fears of audit. So people spending many, many hours looking at potential disallowances and charts. We want to flip that a little bit to focus on the quality of the work, teaching and training people how to document in real time, promoting a lot about collaborative documentation. And one of the shifts in California that's been exciting is services can start at day one in specialty mental health. So we don't have to wait for a 30, 60, even sometimes 90-day assessment to be completed, signed, cross every T before services start. And much more focus on the disallowances on waste, fraud, and abuse, which is a different model for auditing. Thanks, Ritchie. So we're going to pause and just kind of give a quick snapshot of the definition of access and medical necessity, because I think it is a big foundation of what we do. So access, they really tease these apart when CalAIM came on board now over a year and a half ago. Access is really about whether the person is eligible for services. So for children, youth, and families, that's shifted dramatically. And then medical necessity is less about the person pathology and much more about whether the services we offer, the services within a level of care, is clinically appropriate to address the person's needs or condition. So that's a real shift. It feels small to some people, but it's actually a major and significant improvement for our ability to serve. I think we're going to show you the access criteria for kids and youth 21, under 21 in our system. Prior to CalAIM, there was an included diagnosis list. If a young person didn't make it on that list, didn't meet criteria, we could not serve them. There is no longer an included list. So we actually can look. We still really highly believe in careful assessment. Diagnosing is important, looking at those criteria, but we also can serve with a suspected mental health disorder that has not yet been diagnosed. So sometimes that's hard with a developing child, and we might suspect something's going on and be able to start services regardless of that certainty on criteria. And then those updated criteria really take a more prevention, early intervention approach. So young people involved in systems like child welfare, juvenile justice, or unhoused, or at risk of being unhoused. The state has really said we understand the potential impact on those populations for trauma, for negative outcomes. That automatically meets criteria for access. So if a young person is involved in one of those other systems, we can serve without going too far into the assessment. And then impairments, we still have a more traditional approach where if there is a mental health diagnosis or suspected mental health diagnosis and or an assessment of some significant trauma, the young person needs access. And finally, my last slide is on the definition of medical necessity. Putting it here in the slides, you all probably are aware of it too, but wanted to highlight we're excited about this more trauma-informed definition, that it really does take a look at whether our services we offer can meet the needs, do not need to, cure or ameliorate, but really support a young person. So it gives a lot more flexibility in terms of our ability to provide those specialty mental health services. I think the biggest shift of all is, along with this definition and policy, became the ability to provide services even while we're determining that assessment. So even while we're trying to figure out what might be going on for a young person with complex needs, we can begin services and update that assessment as we go. So again, really, really significant and excited about those changes. So that's sort of an overview. Again, might be in your worlds already, but want to shift gears to what we're doing locally in San Francisco CYF to kind of make this all come to life. So I'll pass it on to you, Ritchie.
Thank you so much, Lisa, and thanks everyone. So part of being trauma responsive and trauma informed is to understand, as Lisa has mentioned, underlying factors. And many times those are really the social determinants of health, which is really a primary approach to achieve like health equity. Health equity defined as when everyone has the opportunity to attain their full health potential and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstances. I'm going to show this video just to highlight an equity-centered approach in our thinking about social determinants of health, which was from Anne Green of Yale University.
One day you're in the mountains walking past a lake and see a fish that's near death. I wonder what's wrong with that fish. On your walk the next day, there's another fish sick and dying. And day after day, as you walk past the lake, there's even more fish that are sick and dying. I thought something was wrong with the fish, but I wonder if something's wrong with the lake. As you travel through the mountains, each lake you come to has the same scene, a lot of fish that are sick and dying. I was focusing on the fish, but now I wonder, is something wrong with the source of the water in that region that is making the fish sick? Maybe it's the groundwater that's feeding the lakes in the area. This analogy, developed by the Racial Equity Institute, illustrates our tendency to tie social problems to individual behaviors and decisions, the sick fish. However, racism and other forms of oppression in our history, systems, structures, and policies are the root causes, the groundwater of these inequalities, the polluted lake. These systems and structures shape the opportunities people have to be healthy and thrive in each community, the jobs available and who has access to them, the quality of schools and how that impacts and influences student success, the access to, affordability, and use of healthcare, the neighborhoods and spaces where people live, work, and play, and the ways people interact with each other in all of those settings, all of which are under the umbrella of the term social determinants of health. These are the kinds of conditions and the environments in which people are born, grow, live, learn, work, and worship that affect health.
A few of the social determinants of health listed as priorities by DHCS, or the California Department of Healthcare Services, are right there in front of you. And in terms of thinking about using a trauma-informed or responsive lens, we could think about many of these social determinants of health as also potentially sources of traumatization or trauma exposure for many families that we serve, including homelessness, food insecurity, being targeted with adverse discrimination or persecution. And I know when we think about trauma, many of us are most familiar with the 10 traditional items of trauma exposure that are captured in the ACEs screen or the adverse childhood experiences. But what I liked in the past, I would say decade, is really a paradigm shift in terms of expanding, our definition or operational definition of trauma in terms of also including community environments of trauma exposure. And the new iteration of the PEARLs, for example, the pediatric ACEs and related life events, a lot of the items in part 2 of that measure capture some of the social determinants of health. This one is just a good reminder, and it really also comes from a standpoint of humility, when we approach our work with a trauma responsive lens in terms of how do we understand trauma for clients. We can start with an exploration of adverse childhood experiences, again, the 10 most traditional sources of trauma exposure. But deep within, especially when we're working with diverse families, also really be curious and humble about exploration around adverse community environments, experiences of families that we serve around poverty, discrimination, lack of opportunity or economic mobility and social capital, living in environments or communities wherein they witness ongoing violence, poor housing quality and affordability, and many more. And this pair of ACEs paradigm shift around the ACEs was really started by Wendy Ellis and her team. So how do we shift our practice in behavioral health, especially in assessing for social determinants of health? In our system, we use the CANS as our functional assessment tool. The CANS, or the Child and Adolescent Needs and Strengths, assessment is a multidimensional communication tool to engage the family, children, youth, clients, and providers in the care process. We are now shifting our practice currently right now with the CANS to one CANS for every child or youth or families that is shared by multiple providers. And in a lot of ways, that is very trauma-informed because it avoids potential re-traumatization of clients and families in having to be reassessed multiple times by multiple providers. In being trauma responsive, we are shifting really from that question around what's wrong with you, which is a deficit model of always looking for mental health presentations or symptoms of clients, to a question about what happened to you, right? In terms of really understanding the background of the story of clients. And I remember, and this has been shared, for example, by the model child-parent psychotherapy, and also in other places, do not target for change what you don't yet understand. And with the video I just showed a while back, right, it was the metaphor of a sick fish. I don't really like that metaphor a lot. I prefer really using the metaphor of an iceberg in terms of really capturing the stories of our clients. As an iceberg, many times we focus on the tip of the iceberg, right? In terms of what we prioritize for treatment as behavioral health providers, many times we make decisions around treatment based on the presenting problems. Behavioral and emotional needs like anxiety, depression, risk behaviors like suicidality or self-harming behaviors, impairments in functioning across many domains of functioning, traumatic stress reactions. However, we know that doesn't capture the full story of a client, because underneath the waterline are really background needs, predisposing, perpetuating, precipitating factors that truly account for the full story of a client, now influencing or impacting many of their presenting problems. And so to that question about what happened to you in a trauma-informed way, we need to be really addressing these questions. Now, the CANS luckily has a lot of these items already embedded. The traditional presenting problems, but also many items of the background needs, and many of them really capture the social determinants of health. And this is really an opportunity for behavioral health providers to really think about the focus in terms of really this more holistic focus that really captures what's underneath the waterline. And based on the CANS, this can be mapped into ICD-10 or ICD-11 codes, which eventually based on recommendations from CalAIM, right, to translate that later on into the problem list for a client. So for ICD-10 or ICD-11 codes, we are more familiar with the traditional codes around the presenting problems, right? However, there are also codes that capture social determinants of health. And these needs to be mapped from one's assessment in terms of also capturing them and prioritizing them as equally important needs to consider in provisions of care or interventions for clients. This is just a visual of really thinking about that journey that we are encouraging many of our behavioral health providers in terms of really moving from a very comprehensive, holistic, and trauma-responsive way of looking at their assessment processes, translating that into ICD-10 codes that ultimately lead into the problem list. But part of that bridge is really working with children, youth, and their families in thinking about what to prioritize, right? So many times we might come up with a list of like 10 needs for clients across presenting problems and also background needs. But of course, we don't address all of that in intervention. But in conversations with families, really, having a manageable set of like needs to address in the problem list. And that's part of really the essence of case formulation, right? And once that's clear, then leading that to what ultimately needs to be prioritized in a problem list. And based on that, a conversation with families and also with other providers in terms of what ultimately the family needs or the child, youth, and their family needs around care plan. Is it treatment in terms of mental health treatment? Is it case management or care coordination in terms of linking the families to support systems and resources in the environment that could help support them around their social determinants of health or their background needs? Or are they supportive services that we could just link them to in the community? So that's all part of the decision-making around ultimately what's the care plan for a client. And just to help you understand, our vision in terms of how our CANS assessments translates into this, I think I included in the chat some of our links to our TIPS website in terms of practice guidelines for our behavioral health providers in terms of this vision. To continue that video that I just shared, let me share this latter part of that video.
Health equity is the assurance of the conditions needed to be healthy for all people, regardless of identity. Dr. Kamara Jones offers a framework and checklist for identifying equity-minded solutions. Achieving health equity requires valuing all individuals and populations equally and recognizing and rectifying historical injustices, while also providing the necessary resources according to need. Health disparities will be eliminated when health equity is achieved. To make health equity a reality, we must think critically about the social determinants impacting health. Ask yourself, what are the structural factors that influence the capacity of individuals or populations to reach their full potential for health and well-being? Instead of only looking at the fish, look at the polluted lake and think about the groundwater. Pay attention, be aware of, and create strategies that reach beyond the surface to make the most meaningful steps towards health equity.
In terms of thinking about that groundwater, specifically in helping our behavioral health providers really think about how they can coordinate care and even link families to support services that could help them around their social determinants of health, we have ongoing partnerships with citywide efforts. One of them is this 415 initiative, which is led by the San Francisco Department of Children, Youth, and Their Families, or DCYF, informed by the Mayor's Children and Families Recovery Plan, which found that many families in San Francisco have challenges accessing and navigating the range of services and resources available to them. We often hear this. San Francisco is so rich with resources and programs. However, navigating these resources remains to be a challenge for many of our families. The vision of this initiative is to create almost like a service inventory, a database that will contain information about programs, services, even daily events and resources for children, youth, and families that could potentially help them with any need, whether it's behavioral health or needs that align with social determinants of health. And here's just like a listing of the different divisions and agencies in our city that are helping with this effort. One thing I really want to spend quite time in terms of thinking about and talking to you about and presenting on are our clinical practice shifts. So in terms of shift that really align with CalAIM and in a trauma-informed way, also looking into how can behavioral health providers truly address social determinants of health. It's really shifting our practice from what we grew up learning from graduate school and even in our programming around behavioral health. Shifting from traditional to short-term treatment and to more flexible treatments. Traditional in terms of like evidence-based treatments, shifting from individual to family-centered and also system-focused interventions. Of course, it's very important for any behavioral health provider to anchor one's interventions or services in evidence-based practice and evidence-based treatments. So part of our workforce development effort on an annual basis is to make sure every provider in our system is anchored on evidence-based treatments that are more frequently used for clients or behavioral health clients like CBT. But now in our CBT model, we use a transdiagnostic cognitive behavioral therapy model, which is more flexible in terms of really thinking about what are the most important skills that could be used flexibly with clients. Also, we have dialectical behavior therapy. Shout out to the Wavefront DBT Clinic of UCSF who partners with us in terms of training and also consulting with our system, helping them around this practice. Trauma-focused CBT is another. And also we have child-parent psychotherapy for the 0 to 5 population. Again, shout out to UCSF's Child Trauma Research Program who helps us and partners with us in terms of bringing, training and consultation in our system around this. And most recently too, with the vision of DHCS under their initiative, Children and Youth Behavioral Health Initiative, which is a multi-year 4.6 to 7 billion package of investments that seeks to reimagine the systems that support behavioral health for all California's children, youth, and their families. Part of that vision, that initiative, is to help counties and programs implement and scale evidence-based practices and community-defined practices. For our department, we were so lucky to win 2 grants to support our implementation of 2 practices. One is the parent-child interaction therapy, which is really a model to shift practice to a more dyadic and a more family-centered way of really intervening with the younger population. And MATCH, which is a CBT-based modular approach to therapy for children with anxiety, depression, trauma, and conduct problems, which for me is really in line with this flexible use of CBT treatment, especially in working with diverse communities. And we are lucky to partner with UCSF's Child and Adolescent Services. So shout out to you, Barbara and Will, for helping us with this initiative to really implement and scale these 2 practices in our system. Another shift is really thinking about traditional evidence-based treatments are not necessarily easily applicable to the population that we serve. Like looking at our population at CYF SOC, we serve mostly Black, Indigenous, people of color communities. About 35% of our clients identify as Latina, Latino, Latinx, and Latina. About 20% identify as Black, African American, African descended. And about 12% identify as Asian American, Native Hawaiian, Pacific Islander. And so we serve mostly BIPOC clients. And so it's indispensable to really think about really shifting a traditional way of looking at evidence-based treatment to a more anti-racist, culturally responsive, and equity-centered way of practicing. And so part of our workforce development effort is our ARCH Academy, or our Anti-Racist and Culturally Humble Clinical Practices Training and Learning Academy. We are on our 2nd year of this particular academy, and it's an opportunity to really help our behavioral health providers in terms of really thinking about cultural adaptation. So for example, most recently, Dr. Aisha Metzger, provided a training and consultation in our system around the use of trauma-focused CBT specific to Black or African American clients, wherein it's indispensable to include or integrate racial socialization into the work of CBT in the work for this population. Racial socialization being developing racial or cultural pride, but also being able to really develop or cultivate coping skills to address microaggressions, experiences of discrimination or racism that many Black or African American clients experience on a daily basis. Another is, for example, the work of Alfonso Mercado in terms of thinking about like DBT, especially in working with Spanish-speaking Latina, Latino, Latinx, or Latina populations. So he provided a workforce development effort in our system around how do you culturally adapt an evidence-based treatment such as like DBT, beyond just the translation of materials, but integration of Latina, Latino, Latinx cultural values into the work of doing like an evidence-based practice. Another shift is really in thinking about shifting now what traditionally we view as individual treatment to care coordination or case management. So now it's really indispensable for any clinician to really think about how else could I expand the way I provide services beyond just individual clinic-based like treatment, but going out into the field, linking families through care coordination or case management to really support them around certain services or community resources that could help address social determinants of health. I also wanted to share an example, and the link is in the slide as well, in terms of how this might look like in terms of our practice improvements in our system. So for example, in our TIPS website, we have a section there on clinical practice guidelines. And this is guidelines around some of the most prevalent presentations or behavioral needs of our clients: anxiety, depression, suicidality, trauma intervention, and ADHD. Let me just zoom in on suicide prevention, just so you could see how a lot of these really come together in terms of from doing assessment around suicidality or even like self-harm, using the most traditional or most prevalently used assessment tools, but also making sure, given the population that we serve, really culturally adapting those practices through measures like the cultural assessment for risk of suicide measure for adolescents from the work of Joyce Chu and colleagues. And then later on, thinking about like psychoeducation, how to partner with families and communities around knowing the signs, the warning signs around like suicidality. And in terms of intervention or service provision, safety planning, again, that shift in terms of thinking about short-term versus long-term types of work. So for example, as informed by the Youth Suicide Prevention and Intervention Best Practices and Policy Implications, this was a guideline that was released in 2022. We followed some of the guidelines there and brought it to our system, one being the use of the CARS, or the cultural assessment for risk of suicide measure for adolescents. And another is using a safety planning model that is trauma-informed or trauma-responsive and also family-based around safety planning, which they call the Safety A or Safety Acute Treatment, which according to the proponents of this model can be used in as few as like 15 minutes to about an hour. And it's a very comprehensive, cohesive plan that could be used for children or youth in crisis and those who are suicidal or self-harming around safety planning, but integrated in that is also counseling on access to lethal means. And of course, continued support of that, again, grounding in evidence-based practice around DBT with our partnership with the UCSF Wavefront DBT Clinic, and also other evidence-based treatments like CBT, which is focused on suicide prevention, and the briefer models of like CBT. All right, I guess that's all I'm presenting for my section. And now just want to shift again to either Farah or Lisa to talk about additional system transformations.
Hi, everyone. In addition to some of, this is our last slide, we're going to be closing up soon. In addition to some of the practice improvement and equity initiatives Ritchie just spoke to, there are other system transformation initiatives taking place across our system. We know most of you are already all on EPIC, as well as other sections of DPH, and BHS is finally going to catch up on May 22nd. We are launching EPIC, and it is a huge, it has actually overshadowed CalAIM at this point as the biggest system transformation we're undergoing currently. The transition to EPIC is going to allow for increased care coordination, centralized workflows, focus on equitable and timely access to care for all clients, streamline documentation workflows, and support reduction in documentation time. In addition, we're doing a lot of system transformation related to intensive services in collaboration with UCSF, also folks in this Zoom room and in the room, we were awarded a DHCS infrastructure grant of $33.7 million to renovate the 6th and 7th floor of Zuckerberg San Francisco General to develop a 24-slot IOP PHP program and a 12-bed inpatient psychiatric unit for adolescents. So shout out to Lisa Fortuna and Marina Touloushams, who collaborated with us on the grant, and to Ann Glowinski, Barbara, and Will for supporting this ongoing planning and implementation of these new programs over the next several years. In addition, we're working with our Human Service Agency Child Welfare Department on a crisis continuum pilot grant that they received to expand residential and other home-based placement options for foster care youth. And we're also working with all of our intensive outpatient service providers to adhere to practice guidelines that align with the integrated core practice model, which centers care coordination, teaming, and family-centered approaches to care. So a lot going on in the intensive services continuum. And another thing that I just want to end on is it's probably not a surprise to all of you that we have historically really struggled in terms of our substance use disorder treatment continuum of care. And I'm really excited about the developments that are coming. Our Director of Substance Use Prevention and Treatment Services is working really hard to expand treatment options for youth in need of substance use disorder services. An RFP was recently released to support the development of a youth SUD residential placement. So that is currently in the motion for planning. Another RFP will be released shortly to expand providers delivering substance use disorder, early intervention, outpatient, and intensive outpatient services in line with Drug Medi-Cal organized delivery system. And the SUD prevention services that we currently have will be expanded to address the growing needs of fentanyl and other additional substances. There's also a lot of practice improvement efforts to build the capacity to support co-occurring conditions among our network of specialty mental health providers, because as you know, there is a lot of co-occurring work, a lot of co-occurring conditions that are happening among the youth served in our expansive specialty mental health system. And so on that, there's a lot of other things going on in our system, but we could not end without at least mentioning these three main things. And next slide, I think we have 10 minutes for any questions, thoughts, or reactions from all of you.
Fantastically thorough orientation to the services and where we're going. And I say we are all going. We're all headed in this direction. Thank you for your efforts. I just want a reminder that the auditorium needs to be cleared at 1 o'clock on the dot. There is another event happening, so we will end right on time today and will not keep people over. Then I'm going to be quiet. Questions, please unmute yourself. All right, well, I have a question. It has to do with assessment. As you know, I'm a big assessment person. And Lisa, you mentioned this about like, we're not going to just throw away evidence-based assessment now that it's not, a diagnosis is not required. There's no wrong door. There's no wrong diagnosis, is my understanding. And how do you balance the needs to be accurate and comprehensive and making sure that you're treating what it needs to be treated while also getting people treated, getting them through the door quickly. You know, there's a tension point there, and I'm wondering if you could advise not just you, Lisa, but I'm sure you have lots to say about this. Yeah, thanks.
Yeah, Ritchie, do you want to jump in first, or?
No, you go ahead, and then I will.
That is the tension point. I mean, I think that is the place we need to be focused, though, rather than reading charts for 12 hours a week to see if you had the right criteria met with the right words. So I actually don't think it takes off the clinical need to really know what are we doing with who and how are we getting there. And what Ritchie's said is where our hearts and brains have been the last year in terms of clinical shift. Like, what are the data points we need to look if what we're doing is working? Where did we start in terms of the, for those of you better or worse, the CANS is one of the tools we're mandated to use, where we start with that CANS and where did we end and did we make progress? So I think CalAIM does allow us to breathe a little and look at what our diagnostic criteria are, who we're treating and how, and did we make that progress. So we are hoping to build into Epic some of that kind of data points about progress, about change, using a CANS priority for treatment to really look at a program level. Did we start somewhere and where did we end? So we're actually putting far more time into that now that we're not focused on the latest disallowance round because the words weren't in the right chart. And I'm not here to be dismissive of charting. Like, we really do have high standards. We want to maintain those standards. And people do need to write carefully about the people we serve, but and with the people we serve. So it's not to dismiss that. It is, though, to let us step back and look at what is most important. So I think once we can get through Epic, it really is a whirlwind right now to start looking at how do we look at our evidence-based practice aligned with the assessed needs. So do those match? So we're really interested in data analysis and analytics on what are people saying in the assessment and what are the practices we have had no time in the last 2 decades of my career to ever look at that because we're always trying to put these other rigid things in place. So I don't know if I'm speaking your question, but I don't think any of us have let go of that need for careful assessment. I'm not sure that, we were doing that before with the tools in place, the rigid tools in place. So I actually do think we have a better path forward. So, but Ritchie, you probably have thoughts. We've talked about this so much.
Yeah, I know. I would just share one thing too, Barbara, in terms of your question. I think for us, central to really working in an evidence-based way is to really ground yourself as well with evidence-based assessments. And so even in our use with the CANS, and this was part of our EPIC transformation, when we were developing the EPIC build, we had to make sure, aside from the CANS being built in there, clinicians or providers would have access to many other evidence-based assessments around specific presentations, anxiety, depression, trauma, psychosis or early prodromal psychosis, and many more. And the vision is really meaningful use of the CANS means you have a starting point to organize the story, but to really move towards determining, mental health need, you need a more clinical way of doing an assessment, a more detailed way of really looking at symptoms, in a way that is more structured. So that's part really of that alignment in terms of it.
Beautiful. I'm glad that's recorded. Go ahead, Ann.
Thank you. So first of all, Farah and team, thank you so much for taking time from your also incredibly busy schedule to come here. We really appreciate. I hope you're seeing the comments in the chat because a lot of people are thanking you and also making comments about some of the resources. So I guess my question is kind of related to what Barbara said, but more in line with something really important that you were talking about, Ritchie, which is that we really should take in that some of our traditional approaches are truly not culturally informed, are truly the imposition of a system that may not really even touch or get through families and patients that really need a different approach and framework. And I want to shout out to Brittany. I don't know if she's here because she's an example of one of ours that is really making serious research on cultural adaptations to improve substance abuse treatment in high-risk youth. So I was wondering if, should we be thinking as a division, right, about how we take the specialty expertise that we have, subspecialty expertise that we have, and really look in terms of equity at where are we in terms of potentially culturally adapting and researching basically the effects of new approaches. So this is really a question for everybody. But I think it's very timely and important to be thinking about that. Especially as we're and in terms of how this also really relates very acutely to service development, really thinking about the unit that is going to be developed at a place where we have to offer culturally informed care, no question, and so there will be some low-hanging fruits, but also some things that really need to be addressed as we're building it.
I really appreciate that comment, Anne. And really in thinking about like cultural responsive care, I think it's good to really be humble in terms of like really thinking about it's not a black or white. It's not abandoning what we know as evidence-based treatments to really use like culturally responsive care. So I think the learnings from transdiagnostic modular approaches could be used specifically for this, right? Ground yourself in terms of the principles of treatment, like what works for treatment given different presentations, but use it in a flexible way, especially when working with Black, Indigenous, people of color communities. One example that always is in my heart is Wei-Chin Wang, who created this cultural adaptation for CBT, for Asian populations. And he mentioned in a traditional way, most of the time with CBT, we start with psychoeducation, moving into cognitive coping and emotional coping, and then leading to like behavioral skills like problem solving. But what if the family comes to you asking for solutions to their problem from the get-go? Then why don't you start there? Because that's exactly what the family needs. So it's this flexible way of really using what we know and learned in terms of evidence-based treatments, but in a flexible way that is really responsive to where the client is, especially when we're working with diverse families.
That makes a lot of sense. And I know we have to go, but also it also will require more preventive approaches or more essentially lucid approaches to determinants of health like racism, and shout out to Chase, who is trying to address that in his Muses clinic. But so I feel like there are certain things that also need to be front and center as part of the treatment that currently are more absent, even if we're humble and try to do our best. I think there's also some elephants in the room that need to be dealt with. Anyway, I know we need to leave.
We do, although it's not quite 1 o'clock, but it will be very, very, very shortly. So I would like to take the time to say, and thank you. Farah, you just unmuted yourself. You wanted to say
I was just going to say, Barbara, I think we might have missed some things in the chat, some questions in the chat. So if you want us to follow up offline, we'd be.
I wanted to speak to Shelley, and so Shelley, I'll reach out to you. It's so nice to see you today.
Beautiful. Thank you. I'm sorry that we couldn't answer all the questions. And anyway, have a wonderful afternoon, everyone. Take good care.
Thank you. It was so great to be with you all. Thank you.
Thank you.